So thank you very much for inviting me to come to speak today, and it's always difficult when I have a few hobby horses and this is one of them, so I'll try and talk fast but cover a little bit of ground. I know that many of you will be using simulation, so we'll use the Slido in a minute just to ascertain what's going on. So from a disclosure point of view, I just wanted to say that I'm one of the subcommittee members at the Royal College UK for the development of the Advanced Resuscitation of the Newborn Infant course, and I'm the Royal College Simulation and Technology Enhanced Learning Northwest England neonatal lead, and I founded a pre-ST4 neonatal simulation course together with Professor Ben Shaw from Liverpool, and that's introduced to try and help trainees who are going to be going onto the middle grade rota. So these are trainees who work maybe working, for example, in a district general hospital where the consultant may be at home. And so we've had really good feedback from that course that trainees have found it useful, not just the neonatal end of things, the neonatal scenarios and the medicine, but actually more than that, the human factors stuff, the communication within the team. And they have demonstrated that they use that when they are dealing with pediatric resuscitations as well. So just a little bit of background. So where I work is a large tertiary neonatal unit with, dealing with medical and surgical patients. It's co-located with the Children's Hospital, and we have 60 neonatal cots, of which 17 are intensive care. We have about 10,000 births per year and over 1,000 NICU admissions per year, approximately 6,000 intensive care days per year. We have a large team of 16 consultants and over 250 nurses, lots of rotational doctors coming every 6 months. So there's a challenge for us, but I'm sure it's very similar to where you work, of trying to keep people trained. And we know from studies that have been done in Boston's Children's Hospital, where they looked at what's the chance of you working again with the same team at a resuscitation, for example, of a newborn infant or a child. And it's about 1 in a million of, you know, because the number of people that are around it, so we do need to simulate. The overview of my talk, I'm going to talk a little bit of background, and a little bit about in situ team training that we do, just-in-time training, identifying latent environmental risks, and we've changed recently to doing a lot in that area, and a framework for people who want to develop a sim program if you don't already have one in existence. We found this useful. And some debriefing references. I haven't got time to talk about debriefing, but there are some references for you if you want to look at that. So in the UK, NLS APLS has been around for a number of decades, but in 2011 the Department of Health developed a framework document which allowed people then to kind of introduce simulation a bit more. The Advanced Resuscitation of the Newborn Infant course was developed, and that put a lot of emphasis on communication. So not just the neonatal medicine, but also communication with parents, because it was actually funded to a large extent by the charity Bliss, which is a parent charity. So the Royal College of Paediatrics and Child Health then developed some quality standards. And just recently, there's a draft document out from the Health Education England looking at national framework for simulation-based education. And in that framework, there are 5 guiding principles. Again, these might be useful for people who are wanting to set up programs, just to say, this is what people suggest that we do, therefore we need to do this. So first on your Slidos then, when somebody mentions simulation, what thoughts come to your head? So just type into your Slido anything that comes to your mind. Jessica, do you need to move on? Okay. Okay, so lovely. So stress is there as feature. Training, glad to see in the middle there. Learning, perfect. I'm a bit worried about that. A lot of people are worried that they're not perfect. It's part of the human condition, I think. So we want to improve practice, but we realise not everybody is perfect. Preparation, mock learning, team working. So team working is quite small there, but it's mentioned a few times actually with the space and without. Sick, pretend, learning curve. Thank you very much. So lots of people have different ideas about simulation, and there's a definition. All it is, and nothing to be afraid of, is an educational tool in which a real-life task, event or experience is recreated with the aim of providing a safe learning environment for the acquisition of knowledge, skills and behaviour. And that's what we're looking at in the ARNI course, for example, or here's a picture of an in situ simulation on our neonatal unit. We have 2 isolation rooms, and when this one happened to be free, which doesn't happen very often, then we were able to hop in there and simulate in a real environment. But other things that people might do is power task trainers or chest drain insertion on a rabbit, for example. But not to get too mixed up with technology enhanced learning. So you can use high technology. So there are many mannequins out there at great expense, which we also use, which are very useful. And they are technically very sophisticated as a mannequin. But you can achieve also high fidelity, which is what, by that we mean closeness to the reality of a simulator with very low technology equipment. You may use simulation to encourage people to remember algorithms. And I just want to do a shameless plug for the ERC Resource Council conference, which is next October in 2020. So every 5 years, ILCOR, the International Liaison Committee on Resuscitation, updates the guidelines, and the local life support courses in Europe, not just the UK, and the States as well, will update their guidelines. And these will be launched, as it happens, in Manchester next October. And for the 2 days before the course, so on the 20th and 21st of October, we will be running in Manchester an Advanced Resuscitation and Newborn Infant course, and also in Leeds, which is about 30-45 minutes down the motorway from us. And on those courses, we have set up those courses at that time in case anybody from Europe wants to come. We have 4 places on each course if people want to come and experience that course. So, next question on your Slido, please. So, what kind of simulations are you guys involved with? Do you use low-tech mannequins, both basic and high-tech mannequins? Do you do life support training? Do you do other simulation-based courses, or part task training, or none? And you can pick multiple choices if you wish. So whatever you're involved with, just to give me an idea of the audience. So about 2/3 of people doing life support courses and some simulations with basic and high-tech mannequins. So lots of you have high-tech mannequins, that's great. And lots of you doing UVC insertions or something like that, part task trainers. Some of you also have low-tech mannequins. So I take it from that actually probably 100% of people, there's 5% who don't at the moment do any simulation. Okay, well, I might hopefully try to convince you to get involved in some. So just out of curiosity then, how often do you run the newborn simulation scenarios in your department, whether that's kind of with low fidelity or low technology or high technology mannequins? So I'm really pleased to see that simulation has taken off. I think, you know, in the last 10 years, that if I had spoken 10 years ago, that would be very different. So I'm curious to see just how busy you guys are with simulation. Okay, so about half of you guys are doing simulations every 2 to 6 months. So some people do that maybe with the changeover of doctors. That happens with us every 6 months or so. Also about a third of you doing monthly, once in a blue moon, about 10%, 12%, once or more a week. So we've eventually managed to move to twice a week, actually, by getting money for a simulation fellow. And we struggled for a long time, but there was some education pot funding available from Health Education England, which I grabbed. And then once the unit realised how useful simulation was, once the money had gone after 2 years, there wasn't any repeat funding for that. Our unit managed to fund it from some charity funds because they recognised the importance of it ongoing. And we've managed to get staff involved because of the fact that we have introduced it as part of mandatory training. So it was the case that for 3 hours every year, people had to go over to the resus department and do CPR training on an adult mannequin. So we said to our resus training officer, actually our resus training officer was very helpful and proactive, was paediatric trained by background, and said, look, this is really not very useful for you guys to be doing this because that's not what you do in your day-to-day time. So by managing to introduce it into the mandatory training, it means that all of our 250 nurses get that at least once a year. Now, once a year is not a lot, but at least it's become a culture on the neonatal unit to have multidisciplinary, so nurses, doctors doing some sim training. So some of my slides I think will be just hopefully just to give you some ideas about how to try and convince the people in your area that this is a good thing to do, and to give you either time or a fellow or something that you can deliver it. I mean, I don't think I need to talk to you guys about why it's important to do simulation training. The aviation industry has been doing it for decades and decades, and we're looking at us in medicine saying, I can't believe that you're practicing on real patients. So, you know, you should be practicing on mannequins and such like. This is the Alain Bromley story. I think many of you will know this. So this is about a lady who had a routine operation for chronic sinusitis, and ending up being in a situation of can't intubate, can't ventilate, and died at 12 days of age 12 days later on the intensive care unit. And this Martin Bromley was an aviation, he was a pilot, and he was a safety, patient safety, not patient safety, what do you call that? Passenger safety. Yes, he was a human factors trained, that's the word I was looking for, sorry. Human factors trained pilot. And so I show this video at the beginning of any of my sim courses, because it highlights that all of the people who were involved in her care were very experienced, highly trained, very competent at their job, and yet when it came to the situation of looking after this lady, there was a poor outcome. And so in newborn life support, we have gone, yes, newborn life support, basic training, everybody needs to know how to do bag valve mask ventilation or put the head in the neutral position. But actually it's much more than that, and it's all about the team skills and the communication and the being able to say, I think there's a problem here. And on our unit we're all speak to each other by first name and ask our juniors to call us by first name terms. And I think that helps, or hopefully that will help also to reduce the hierarchy a little bit and allow people to speak up. I'll skip over this, and these are the examples I'm going to talk through. So we'll just go through them bit by bit. This is our current sim fellow. She's given me these slides, so she's beheaded herself. It wasn't me on this. So she obviously doesn't want to be in the picture. But what people had identified on our unit was that when babies were deteriorating in incubators, people were trying to resuscitate them by putting the door down or through the portholes, and actually weren't managing to get very good chest movement. And we were trying to teach the practice point of please turn the baby around so that you're in line with the baby, as in this bottom picture here. So what she did is she set the neopuff pressure at 30 centimetres of pressure, and she got 12 participants to see what kind of pressures they could achieve with a one-person technique with the baby at 90 degrees to them, and that's in blue. With the two-person technique, baby at 90 degrees, or by turning the baby around so that you're directly in line with the baby. And she's shown that with the one-person technique, the blue lines, people were able to achieve, one person was able to achieve about 22 centimetres of water pressure for a neopuff that's been set at 30. So got a bit better with the two-person technique, but all of them managed to achieve what the neopuff had been set at by putting the baby in line. So this was then cascaded back to people in a 2-monthly little newsletter to all the staff on the neonatal unit that, you know, was got a bit of evidence that shows that, look, it's best if you turn the baby around and be in line with the baby when you're delivering the breaths. So on our unit, we also do debriefing. Anybody that you talk to who does simulation will tell you that the scenario is only an excuse for a good debrief. People do learn during this scenario, but actually a lot of the learning happens with the team debrief afterwards, and very important to allow the team to vent their frustrations or their experiences. And I'm always amazed that even when things went well, the amount of people that think, oh, that was terrible. And you can't, and again, part of the human condition, I think, that everybody, we need to build each other up and reinforce all the positive. We also have used simulation for reorientation of care. And this is in one of our technicians. Our technicians have an office on the unit, so when we don't have any space in the unit itself, we can use mock up an intensive care space there. And so the first scenario here is where the team discuss, you've got 2 nurses here, and then you have 2 people here pretending to be, these are nurses, but they're pretending to be the mum and her sister and the doctor, who are around the patient who is intubated, ventilated, has a chest drain in, is on inotropes, morphine, and they have a discussion about how are they going to move this baby to our, what we call our Snowdrop suite. And they decide which kind of infusions can be stopped and how are they going to go about that. Then they speak to the mother and her sister, or simulated mother and sister, about what they're planning on doing. We're very lucky on our neonatal unit because we are a busy unit and a tertiary unit co-located with the Children's Hospital. We have about 50 deaths a year, so we get quite practiced at using this room, which is quite a busy room. It's a room on the neonatal unit that's been furbished from a bereavement fund. This is a sofa bed here, which pulls out into a sofa. This is another sofa here. There's some oxygen points here at the back for oxygen and air, so we can bring the baby in here, still ventilated. The family can take their time. It's an ensuite room. All the other children can come in. They can bath the baby, whatever. So in this simulation, the second part of the simulation is once they've moved the baby into this room, another group then talk about compassionate extubation. Extubate the baby, pronounce the death, talk to the family, offer the condolences. So they rehearse that. And it's amazing because people don't normally haven't done that before. A lot of the staff haven't done that before. And we've spoken to people afterwards, and they have told us that when they next were then actually involved with a baby who had died, many of them hadn't yet been involved, when they then were involved with a baby who had died, they used a lot of the phrasing or the experiences that they had taken from the simulation, and they felt much more comfortable at doing this. So our first simulation fellow was Jonathan Herst, who developed this framework as part of his university module on simulation, and it's in the public domain now. It's been published, and I think it's quite a useful way of looking at things if you are trying to develop a sim program. In the blue are thinking about your learners. What are your drivers for developing a sim program? Who are your learners and what are their learning objectives? Then what kind of educational practices or models do you want to use? For example, do you want to send them the guideline before you, or if you're planning on simulating an supraventricular tachycardia, do you want to send them the protocol beforehand, let them know what they're supposed to be doing? Or with the bereavement scenario, it's a good idea for them to know before they come in that that's actually the scenario that they're coming to, because it might be that they've recently been bereaved themselves or some other reason why they might not want to participate. And so there's some things that they can read about before they come. Who are the facilitators going to be? So, don't build a sim program that relies just on you. You need a buddy, at least one. What are the pressures? Then the scenario design. There are many scenarios out there already that you can use. You don't have to reinvent the wheel. Debriefing, lots of people worry about. So if you can send people on some kind of a debriefing course or something so that they feel a little bit more comfortable, because otherwise I think you'll find your facilitators shying away from doing that. And very important in the green, this is the bit for how you can convince your department to keep funding it once the fund has gone for whoever's left. Our first sim fellow who has left after his 2 years or for whatever reason. And some of that can be quite simple. So then in obstetrics, for example, there's a national insurance scheme that they have to pay into for litigation, and they get a reduction in their fee if they have a certain number of midwives trained. So there might be other things like that you can look at. So one of my obstetric and aesthetic colleagues, Dr. Kirsten McClelland, is frightfully enthusiastic obstetric proponent, simulation proponent, and she has written this book, which is just published last month. And in that is that framework from Jonathan, but also if you have any obstetric colleagues and you want to do joint multidisciplinary simulation, and they need some scenarios. This is they've got a lot of scenarios in, but also the background, the current updates and current practice. So we showed that there is, we evaluated our response to the people participating in the bereavement scenarios, and I mentioned this already, we showed a Kirkpatrick level 3 change, so a behaviour change. Risks in hospital, I think, is a very easy way to get into doing simulation, because we need to start talking the same language as our managers, and they all sit up when you start talking about risks. And international studies have shown that adverse event rate of 2 to 10.8% in hospitalised children aged 0 to 17 years. That's 2 to 10% per admission. But actually the main risks are in neonates, of whom 17% have incorrect procedures or treatments, 12% medication errors, unexpected admissions or transfers or readmissions. So armed with this kind of data, you've got a strong case to bring to why it's important to do simulation. You can look at various reports in your area, like the National Patient Safety Agency, who have reporting and learning services online. You can just look under neonates, search the categories, and they will give you examples of cases that have been reported. The Confidential Inquiry into Maternal and Child Health report of why children die found preventable factors in about 26% of cases. Serious hazards of transfusion, hospital mortality reviews, etc., etc. So try to talk the same language. I just have a small video that we did of a power failure. So one of the people involved with me in the simulation said, it might happen that we have a power failure where the generators don't kick in, and what do we do then? And I said, does that really happen? And they said, oh yes, it does. So I said, okay, fine. So this is a little video. It's a little bit loud. Just be careful. Glad you like that. So what that showed is there was this wall between, we were in the neonatal resus room just outside the theatres, and that wall, the doors between the theatre and the neonatal resus room was such a barrier. What happened, we had no idea what went on in labour in the theatre, and theatre staff didn't know what happened in the neonatal resus room. Both of us were trying to contact, or both of the teams were trying to contact switchboard to find out, is this power failure local, or is it the whole hospital? Can we move to a different area? And so we realised these physical barriers are really important to remember, and somebody just opening the door would have been so helpful in that situation. So beware of doors. When we asked people what they enjoyed most or what they found enjoyed least, what they said they enjoyed most was the fact that it was a multidisciplinary drill, that they had a good opportunity to practice, that it felt real, thinking outside the box, having to learn about what to use, what backup to use. And what they didn't like was the fact that there weren't any batteries with lights. Everybody was there with their iPhone with the light on. But then we said, well, you know, what about if this power failure lasts for a few hours, then everybody's battery would be dead. And so they finished the operation with the lights of the phones, but the scrub team felt excluded. So you learn things like this. So we then fed back and about what we might do differently. So people learned about how long monitors last, and we got some torches with lights, extra batteries and stuff like that. So we haven't simmed it again, but we will do. So here is another situation, just a brief example of a category 1 section for prolonged fetal bradycardia, when all the obstetric and gynae theatres are full. So in a weekday where they have routine gynae operations happening, we cannot use the gynae theatres, and so what they decided to do is simulate to do the operation in the anaesthetic room. So they wheel the mannequin into the anaesthetic room, the doors open inwards there on the top left, and then all the scrub team were stood outside, already scrubbed, nice and sterile, but couldn't actually get in because everybody was now in, so they had to figure out a way of how they move half the people out again so that the scrub team could get in. And then the neonatal team, poor relation, were on the corridor. So they found a resuscitaire, wheeled it down the corridor, plugged it in. But then they needed to plug in suction. But the obstetric team had used the plug for their suction, which they needed for the mum, for the cesarean section. So somebody had to go off and find multi-plugs. Then they were happy. They could plug in. They found another suction device for the baby, and they could now plug both things in, both the resuscitaire, which was going off the cylinders. Baby was delivered. The team were all ready, and even though they were on the corridor, it all went to plan. And at 3 minutes 43, the baby was intubated, having his tube secured. Lots of people around. On a busy corridor where the gynae theatres is still at one end and the obstetric other theatres are at the other end, everybody passing in the corridor. By 12 minutes then they were ready, packed up their resuscitaire and moved the resuscitaire down the corridor to some place that was a bit quieter. So they identified a number of issues, but this is actually a real possible problem in a busy obstetric unit, that you might have all the theatres full. So what should we do? And so we developed a contingency plan to use a larger theatre. They then theatre anaesthetic room. So there's another anaesthetic room a bit further down the corridor, which was a bit bigger. And then they put a sign on the wall about where to plug in the resuscitaire. So this is the long corridor. So go further down the corridor, and then they put a little sign on the wall that says plug your resuscitaire in here. And there's plugs down there. But most recently, about a month ago, we simulated the same thing again, and we found that these plugs were now hanging off the wall. So somebody had crashed into the socket. So do resim the thing, because whatever you plan might not still be the same as what you thought. This one I just want to show you, the birthing pool, the bane of all of the neonatologist's life. So Kirsty, my anaesthetic consultant colleague, just also hates being in this room and said this is really risky, but was always reassured, don't worry, we have a hoist, if anything happens to a mother in the bath, no problem at all, we'll be able to get her out. So she said, that's fine, let's simulate it. So convinced her medical student that he should wear theatre scrubs, get in the bath, fill it with water, and pretend to have an eclamptic seizure after having delivered the baby. Medical students will do all sorts for, sign my competencies here. No. Anyway, so he was inside in the bath, had delivered the baby, the neonatal team were there, resuscitating the baby. Thankfully, he had the eclamptic seizure after the baby was born. So there are several people here trying to get him out of the bath. Now, this is a slim chap with a beard who is in the bath. Here you can see him. So they left the water out of the bath, tried to get him out, filled the bath up with water again, thought that might help, then left the water out again. They're all standing around here thinking, how are we going to move him out? They tried to find the remote control for the hoist. That's kept at the nursing station. So somebody runs to the nursing station to get the remote control. Then they come back and then they realize it's not got any battery in because something else has been plugged into where it should have been plugged in. So that doesn't work. So they go and get a different hoist, which from one of the normal other rooms, but that doesn't actually fit around the base of this birthing pool. So then they get this paper, turns out later it's made of paper, they didn't know this at the time. So paper in this wet bath with this poor chappie in, and it's 30 minutes later when they managed to get him out of the bath, out of the birthing pool. So this is very powerful stuff. When you go back to your midwifery department, managers of labour ward and say, this is what's happened. So they decided then they needed to do a complete risk assessment for the pool and its equipment, that nobody was left into that room, into the birthing pool again, until they had checked that the remote control was working, that the hoist actually moved, and they also spoke with the trust about getting an alternative, kind of a net thing rather than something made of paper to fish somebody out of water. So, have you noticed any worrying practices in your environments or in your workplace? If you do, worrying won't stop the bad stuff from happening. So it just stops you enjoying the good. So just sim it, stop it from happening, and then sim it again. Disseminate the evidence, implement the change. So my top tips are identify a sim buddy. All best things happen in pairs. So you've got Laurel and Hardy, you've got Stefan and Francesco. It works well if you've got a buddy. Find a sim buddy. Get the neonatal nurses and allied health professionals on board. Find people with other roles. I didn't know Kirsten McClelland. Our department is so big. She's an obstetric anaesthetist doing all this simulation just the other side of a door from my department. And it was somebody else within the trust who's saying, do you guys know each other and you're doing similar stuff? So find out what other people are doing. It was amazing. I couldn't believe that all this was going on that I didn't know about. Resus training officers often have a bit of an overview of what goes on in the hospital, so they're also really good resources. And a little bit of debrief training for the facilitators so that they feel comfortable, but the aim is to try and get the participants in the resus to debrief themselves. If you can do in situ stuff, that's really valuable because that actually shows what happens in real life. And we've now got buy-in to use the equipment there. You don't use a lot of equipment, and actually it's so much more useful than mocking up a resus trolley that isn't exactly the same, or that doesn't have the things in the same layout. If you're concerned, sim it. In your debrief, be honest. You know, there's no point saying it was wonderful if it wasn't. Do be honest, but be kind, because of the human condition being very fragile. Thank you.